Hello, I'm Faisal Latif. I'm an associate professor of medicine at University of Oklahoma. I've been tasked to talk about imaging to guide treatment of calcified coronary artery lesions. Here are my disclosures. Coronary calcification is very common, seen in more than 70% of lesions by intravascular imaging. There are various risk factors, including advanced age, renal disease, and diabetes, and post-CABG status. However, fluoroscopy is inadequate in determining the calcium. Here you can see some calcium on fluoroscopy, but when you inject dye, it's hard to tell if this calcium is intraluminal or is it deep calcium, and therefore intravascular imaging becomes important. This is the same patient where the CT of the coronary arteries showed a score of 836 in the LED, and again it is difficult to determine where this calcium is. Is it in the lumen or is it deep? This slide shows the comparison of IVUS and OCT. IVUS can show us whether this is superficial calcium or deep calcium closer to the adventitia, and particularly this hyperechoic signal from the IVUS shows the arc as to whether it's 180 degrees or it is close to 360 degrees. Here on the OCT side, we can determine many more features, such as the thickness of calcium, the longitudinal length of the calcium, which is an important factor in determining whether a patient needs atherectomy and what kind, eccentricity of the calcium, and whether the calcium is concentric. You can see the relative efficacy of these imaging technologies. While severe calcification can be determined either by angiography or intravascular imaging, however, the thickness of calcium, the longitudinal calcium length, or whether the calcium is deep or superficial is much better appreciated with intravascular imaging. Here you can see the concentric nature of calcification, how this image shows that around 12 o'clock to 3 o'clock there is very thick calcium in this particular lesion. This is a nice demonstration of calcium in the left main and LAD. You can clearly see on both sides of the vessel wall. IVUS shows that it is all superficial calcium, which is about 270-degree arc, but then OCT not only it shows the 270-degree arc, it shows how thick the calcium is, and therefore it can help determine how to manage this lesion. This algorithm here shows that if there is angiographic calcification, if it is mild, you generally don't need imaging to determine how to treat it. You can just treat it with scoring balloon or cutting balloon. And on the other hand, if it is severe, then you know that you need atherectomy. It is the moderate calcification where intravascular imaging is very helpful in determining the next course of action, whether you need to go towards scoring or cutting balloon, or you need to go towards atherectomy and then stent implantation, which can be optimized with imaging guidance. Here are the various balloons that we use in these calcified lesions, the cutting and scoring balloon and their characteristics. Here are some results that you can see in the in-stent restenosis, where the cutting balloon or the scoring balloon create these fractures in the calcified in-stent restenosis, and then with an optimal sized balloon, you can get a very nice angiographic result. Lithoplasty balloon is another specialized balloon which delivers pulsatile mechanical energy to disrupt these lesions and get an optimal result, as is shown in angiography here, and you can see the OCT results here as well. Rotational atherectomy can be very useful in obtaining stent optimization through lesion preparation. You can see in this image the OCT catheter is close to the vessel wall, which shows the extent of calcium, pushes the imaging catheter towards one vessel wall, as compared to the segment in E here, where the imaging catheter is more centered. Here is some result with orbital atherectomy, where you can see that after stent implantation there is a nice cracks of the calcium you can very well see. Both these modalities have their own particular uses, and they can be used in accordance with intravascular imaging. Let's look at a case here. This is a patient on peritoneal dialysis, about a 60-year-old gentleman who came in with non-SC elevation MI. 7 months ago, he had an LED stent that extended from mid-LED into the large second diagonal. You can see severe in-stent restenosis, and there is very aggressive edge restenosis with severe calcification. We could not even get an IVUS through before doing an angioplasty with a 2.5 balloon. And here is you can see that there is 3-quadrant calcification here. And in this next slide here, you can see that there is actually concentric calcification in that proximal LAD. By the way, this patient was not a candidate for CABG, and therefore a percutaneous route was used. The problem is that what is the actual diameter of the vessel there? Because in concentric calcium, you cannot see it with the IVUS very well. And even with OCT, you will not be able to tell the size of the vessel. The proximal vessel is about the proximal vessel is about 4.5 millimeter in diameter. And if you go a little bit further proximal in the LAD, it's almost 5.5 to 6 millimeters in diameter. So how to size this? So we used orbital atherectomy because I felt that rotational atherectomy will not touch the walls enough to get adequate ablation of this calcium. And therefore we used orbital atherectomy, achieved a diameter of 3.0, put in a 3.5 drug-eluting stent, post-dilated to 4.0, and here you can see a quite satisfactory result on angiography afterwards with the tapering of LAD into D2. Here is a calcium scoring system which takes 3 important parameters into consideration. The calcific arch, if it is more than 180 degrees, the thickness of the calcium, and the longitudinal length more than 5 millimeters. If these 3 factors are present, the risk of stent under expansion is high without use of atherectomy. And here is an algorithm where if you have calcium arch more than 180 degrees, calcium length more than 5 millimeters, and calcium thickness more than 0.5 millimeters, then you are better off using atherectomy to obtain optimal balloon expansion. And if you still don't get optimal balloon expansion, a lithoplasty balloon can be used before implanting the stent for optimal results. Here is another OCT-based algorithm, which is quite similar to the previous algorithm. However, it adds that if there is nodular calcium, then you are better off using atherectomy because that nodule is not going to break without use of atherectomy. Here are some tips and tricks. So see, when you are imaging, if the relative position of your catheter is closer to the wall, then that's probably eccentric calcification. And then you want your atherectomy burr to touch that calcium. So if you are just using a rotablator, maybe you need to use a larger burr. Or if you think your rotablator burr is not going to touch the wall, then maybe you're better off with an orbital atherectomy like I showed in the case that I showed a bit earlier. The other thing is lesion crossability. If the lesion is really uncrossable with a balloon or any microcatheter, then maybe you need rotational atherectomy because the orbital atherectomy has a nose cone, which if it cannot cross the lesion, you will not be able to get ablation of the lesion. So here is a summary. I hope I have been able to demonstrate that angiography is suboptimal in determining calcific lesions. Intravascular imaging should be used not only to determine what kind of device to use to treat these lesions, but also to get adequate interventional outcomes. Thank you very much for your attention.